Again, I provide the entertainment during these meetings. So my job over the next few minutes is to talk to the fellows and the folks that have been in practice the shortest and give them some advice about things that they are going to face and potentially face at places even after they've been in practice for a while. How to overcome challenges in practice. These are my disclosures, not germane to this. So I'm just going to touch on four common challenges in practice, especially early on, is developing case volume, introducing new technology into a center where you don't have a reputation yet, dealing with specialty competition, and local politics, which is what all politics are. Before you start, I think you should understand a few things. Maybe they're uncomfortable truths. One, you were not brought into this practice because your group was just too busy. You would probably not be doing all the complex cases despite the fact that's what you thought. Your experience in fellowship will be minimized very quickly by those that have been around there longer than you, and the competition will probably magnify the mistakes in judgment that you make, especially when you have bad outcomes. So the idea is to collaborate. And the cath lab staff and the vascular staff will not be open to your new ideas because they've never seen some of the stuff that you're going to bring to them, and they may never get that way. So early practice do's and don'ts. Don't overwhelm people with your newfound skills. Be discovered for the kind of work that you can do and develop a local reputation of early adoption, and that's probably the best advice I can give you. So what's challenge one? Developing your case volume. So one, be professionally honest. Don't do cases you're not comfortable with. Be very clear about your upfront experience and just collaborate with people, because when you learn something, you can see one, do one, then teach one, you'll get plenty of cases over time. How do you find the patients? Well, people say, I don't have any vascular patients in my practice. Well, if you're a cardiologist, you're wrong, because your coronary disease population is full of them. Many of them are symptomatic and they've just never been asked. And many of these patients have lifestyle limiting problems, which are the only ones you should be treating. Screening for things like carotid and AAA are important parts of vascular practices, and venous disease is absolutely part of your evaluation. And then developing outreach clinics. So building the referral base to increase your volume is from within your practice. How do you do it? Teach your non-invasive testing to your partners. They may not even know how to do appropriate ABIs or some of the things like Josh had just shown us, how patients should be followed after they have surgical procedures. Teaching angiography, I taught pretty much everyone around us how to do good peripheral evaluations and make sure people are clear on what the indications are. We have screening programs in our practices, and I think that those are things that are easy to incorporate. Duplex, segmentals, and also patients that have symptoms could only ones to be treated. How about outside your practices? Sure, educate people, podiatrists, PAs, NPs. Many of them have no idea how to evaluate patients with vascular disease. You teach your referral base that if someone has a wound, that's not something that's going to get better with Pletol. You actually need to try to improve the vascular space, and then be clear on indications, especially if you're starting new things like what's coming up now with TAVR and left atrial appendage closures. So people ask, how do you develop outreach? Usually it's because you have a relationship with an outlying clinic. So we started in Dallas 20 plus years ago, and there are outlying areas like in Greenville, which is 50 miles away, and we had a very good relationship with the hospital there, and then we put a satellite center out there, very much of a spoken hub. Been there for almost 18 years now. Kaufman the same way, about 30 miles away, and in Rockwall the same way. So these are places where we have great relationships, and they're very much of a grassroots way, and those are places where people can count on you to answer the phone when they need something off their plate, and I think that's how you start to develop these outreach clinics. Challenge two is introducing new technology. So early adoption of devices is one way of introducing new technology, but the technical challenges are not as big as the political challenges. So you have to educate people. You can be identified as a local expert if you're teaching people and you're incorporating research that elevates your level of education to people. Refine how you do presentations, not using industry slides, learn new procedures, offer to present those and teach people about them. But the important thing is that people recognize that you're actually someone who is adopting new procedures, and you're not going to shove that new information down their throat, but you're going to incorporate them into growing that. People need to see that you are the recognized leader, and you have to make yourself educated, and you have to make yourself uncomfortable. Really, every year you should be learning something new, if not more frequently than that. And if you're not considered an early adopter, people will sort of overlook you. If you haven't educated your community, they won't go to you for that kind of thing. So incorporate new procedures every year. We did this starting in practice in '96. I learned how to do laser, which people say, okay, you're an expert in this, but over the years, a bunch of other things come as an early adopter, and over time, all of these things, percutaneous AAAs to TAVRs, are things that are presented to you because of patient volumes, and that's how you make yourself uncomfortable every year, is you actually incorporate these things, and if it's not you, it's someone in your practice that actually takes on that energy to learn these new procedures and make themselves uncomfortable. The third challenge is dealing with interspecialty competition. That's the surgical versus the endovascular. And I think the best thing to do here is just have the open collaboration mentality. I think it's difficult in the current system of payment because it is still a fee-for-service model, and until we can come up with a way to change that, this will be a continued issue. But I think that there's no substitute for doing good work. So sometimes when I see endo work being done by cardiologists and I don't see good images of the tibial vessels, or I don't see good decision making, I get very frustrated with my own colleagues, because that's not the way that you can actually compete, because you are doing a lousy job of that. So know the field backwards and forwards, and do good work. And the last is dealing with local politics. And this is a reality, because in your local center, no matter how much you adopt early technology and no matter how much you educate people, there still will be some roadblocks. The first thing to recognize is that everything is a process. So being a complainer is not going to work. Once you get that out of the way, you have to understand, how do politics actually even work at your hospital? Ask some of your mentors, ask some of your colleagues, change the status quo with excellence, and use data to influence instead of being just loud about things. Be flexible when you can and educate the staff. Don't rant and rave. It really just never does work. And the last thing is, don't be an outsider. So getting into committees, getting on organizational systems where you are part of the solution and not part of the problem, and part of the actual hospital leadership, I think is a good way to get yourself to be listened to and to be able to adopt new technologies as they come to you. And invite other people to speak at the educational programs that you do, even competitive groups. And with that, I think you'll do a really good job. You create a team mentality with you in the middle, the cath lab, the surgeons, the patients, your colleagues and administrators, and you'll ultimately win in the long run. Thank you very much for your attention.